Good morning, everyone. I'm Joel Katz at Brigham and Women's Hospital, and on behalf of my colleagues, Dr. Eileen Reynolds at the Beth Israel Deaconess Medical Center, and Dr. Jose Flores at Massachusetts General Hospital, I would like to warmly welcome you to the October installment of our combined Harvard Medical Grand Rounds. And we have a great group of panelists today who I'm about to introduce, but I want to remind participants throughout the presentation to please submit your questions through the chat function, the question function in the webinar. Today's speakers, distinguished speakers, are in order: Dr. Greg Fury, who is the Medical Director for Climate and Sustainability at Brigham and Women's Hospital and an instructor in medicine at Harvard Medical School. He will be followed by Dr. Preethi Malhotra, who is the Senior Medical Director for Infection Control and Hospital Epidemiology at the Beth Israel Deaconess Medical Center and an Assistant Professor of Medicine at Harvard Medical School. And our final panelist today will be Dr. Winnie Armand, who is the Associate Director for the Center for Environment and Health at Massachusetts General Hospital and an Assistant Professor of Medicine at Harvard Medical School. And today our panelists will be talking about a critical national health emergency, healthcare sustainability, transforming clinical practice in the face of climate change. Thank you very much. Dr. Fury?
Great. Thank you so much. We really appreciate the opportunity to speak to the group. I'm just going to pull up my slides here. All right. Well, thank you again. So first of all, I just wanted to mention that none of us have any conflicts to disclose. And then I just wanted to go over our objectives for today, which are to recognize the U.S. health sector's substantial contribution to climate change, using data from Mass General Brigham's greenhouse gas inventory to highlight some important sources of healthcare emissions, and to understand how clinical activities drive carbon emissions and represent opportunities for mitigation through the use of two examples relevant to internal medicine: single-use first reusable products and low-carbon asthma care. I'm going to be starting off by providing an overview, and then I'm going to turn it over to Dr. Malhotra and Dr. Armand to provide a deeper dive into two examples that illustrate how clinicians are approaching the challenge of reducing the environmental impact of clinical care and where there's alignment and tension with other priorities in clinical medicine. So I know this is familiar to many of you, but still think it's important to start with a brief recap of climate science. So the concentration of CO2 in Earth's atmosphere, shown here at 417 parts per million in 2022, is unprecedented in the past 800,000 years. The previous highest concentration during that time was here at 300 parts per million. And the science is clear that this rise is due to human activity, primarily the combustion of fossil fuels, deforestation, and our agricultural practices. And that's shown here. The rise in atmospheric CO2 concentration, shown in blue, tracks closely with CO2 emissions, shown here in gray. And as you're all aware, rising CO2 concentrations depicted by the gray line here are highly correlated with rising average global temperatures due to the greenhouse effect, in which solar radiation is trapped inside the Earth's atmosphere. And as becoming increasingly clear with each successive extreme weather event, both locally and globally, the implications for health are really sobering. And that's why recently, for the first time ever, over 200 medical journals, including some pretty reputable ones, published a joint editorial in which they stated that the greatest threat to global public health is the continued failure of world leaders to keep the global temperature rise below 1.5 degrees Celsius and to restore nature. And of course, the health effects of climate change are not limited to the impacts of extreme weather events. This is a figure from the New England Journal showing how increasing levels of CO2 and short-lived climate fluids are driving rising temperature, rising sea levels, and increasing extreme weather events. And through various exposure pathways are having direct and indirect effects on human health that affect essentially every organ system in the body. And importantly, the magnitude of those effects and their distribution among populations are influenced by a number of demographic, socioeconomic, and environmental factors. And it's critical to point this out because we know that climate change disproportionately affects the health of vulnerable populations. Many people believe that climate change is the greatest public health challenge of our time. I'd argue it's also the greatest health equity crisis that we currently face. And for those of us in healthcare, here's the paradox. We're a major part of the problem. If the global health sector were a country, it would be the 5th largest emitter in the world, and the US would be the 13th. And why maybe you aren't aware of those statistics, I suspect that many of you intuitively sense that the health sector has a substantial environmental impact. Think about the Longwood medical area, 3 quaternary care centers operating 24 hours a day, a major cancer center, schools of medicine and public health, biomedical research labs, and a power plant all within a 3-block radius. And then there's another campus very similar to that right across town. The environmental footprint of these facilities is immense, and it's exerted through many different pathways. For example, through the manufacture and disposal of all the products we use, transportation, agriculture, water use, all which are associated with significant greenhouse gas emissions, as well as other types of pollution. And of course, there's emissions just from generating the energy necessary to power, heat, and cool these facilities. As healthcare professionals, I'd say this should make us uncomfortable. Healthcare-associated pollution, including contributions to climate change, adversely and inequitably affects human health. In fact, a recent study estimated that pollution from the US healthcare system, including contributions to climate change, is responsible for 244 to 531,000 disability-adjusted life years annually. That's the same order of magnitude as preventable medical errors into errors is human, the IOM report that catalyzed the entire quality and safety movement and completely changed the way we practice medicine today. And I hope we can agree that contributing to death and disease through the environmental impacts of our operations is fundamentally at odds with our mission. If we agree it's our professional responsibility to first do no harm, then we have a moral obligation to address healthcare's significant environmental impacts. So today we're going to focus primarily on greenhouse gas emissions, although there are clearly other forms of healthcare-associated pollution that harm human health. So this diagram is from a recent carbon footprinting analysis of the UK's National Health Service, which shows sources of emissions using a typical framework for greenhouse gas accounting that divides emissions into Scope 1, Scope 2, and Scope 3. Scope 1 refers to emissions that are produced directly by facilities, including combustion of on-site fossil fuels, released anesthetic gases and refrigerants, and emissions from an organization's vehicle fleet. Scope 2 emissions are those attributable to energy purchased by an organization, but not produced by it, so electricity and steam primarily. And then last, Scope 3 emissions are those attributable to the supply chain, waste streams, water use, construction, transportation. Importantly, greenhouse gas emissions include not only CO2, but also other gases that are commonly used in modern medicine that have far greater heat trapping potential than CO2, such as inhaled anesthetics and the propellants in meter-dose inhalers. So what are the main sources of emissions from healthcare? This is data from an analysis of the entire US health sector, showing Scope 1, 2, and 3 emissions from 2010 to 2018. Most recently, in 2018, US healthcare-associated emissions represented 8.5% of total US greenhouse gas emissions. And our per capita emissions from the US healthcare sector are the highest in the world. Notice that our energy consumption, or Scopes 1 and 2, contribute less than a fifth of total emissions. Scope 3 emissions represent the vast majority, and that's a finding that's been seen consistently in studies of the health sector. Importantly, this analysis doesn't include contributions from meter-dose inhalers or anesthetic gases, nor does it include substantial impact of biomedical research that's conducted at many academic medical centers like ours. So, as you can imagine, in order to reduce healthcare's contribution to climate change, we need to understand sources of emissions at a more granular level. And to that end, many organizations that are seeking to reduce their carbon footprint, MGB recently completed an inventory of its greenhouse gas emissions, including all clinical, research, and administrative operations. And consistent with studies of other health systems, Scope 1 emissions account for about 9% of our total footprint, and Scope 2 for about 7%. The vast majority, 84%, is due to Scope 3. And the largest contributor is purchased goods and services, or the carbon associated with the manufacture and transport of all the supplies we use to deliver care and conduct research. This is followed by capital goods, including construction and renovation of buildings, but also large expenditures on durable equipment such as MRI machines. Other notable categories include upstream fuel and energy. These are emissions that are associated with the extraction, production, and transportation of the energy that we consume, and would presumably go down if we were less dependent on fossil fuels. Employee commuting and patient travel also make up substantial contributions. So if we look more closely at purchased goods and service, we can see that pharmaceuticals used in the inpatient setting represent about 10% of our footprint. And importantly, this doesn't include emissions from pharmaceuticals that are sent to retail pharmacies in the outpatient setting. In that study of the NHS that I mentioned, emissions associated with prescriptions just from primary care were greater than those from all of the medications administered in the hospital. And a main driver of that are within primary care are meter dose inhalers, which we'll hear more about shortly. And then much of the remainder of this category is made up of all the consumable products we use. And that's driven at least in part by a continual shift in medicine towards reliance on single-use disposable items. And we're going to hear more about that as well in a bit. You'll notice that this inventory excludes emissions that are associated with our investment holdings, and those are also likely a substantial contributor, but not represented here. So this analysis begins to provide us with some high-level insight into the sources of our emissions and serves as a starting point for implementing initiatives to address our carbon footprint. But many questions remain. For example, what are the relative contributions of different clinical service lines or types of research programs, of different diagnostic and treatment approaches, and of the specific products that we use? Moving forward, we'll be working to generate even more granular data that helps us prioritize for and approaches to intervention. And fortunately, there's accelerating interest in this field, and so that data is coming. There is one thing that is clear, however, and that is that there's no single solution to healthcare sustainability. We're going to need to implement a suite of changes, as highlighted by this wedge diagram, that outlines how the NHS plans to achieve net zero emissions across all scopes. I'm not going to go through this in detail, but I want to point out that the interventions fall broadly into 4 categories, specifically decarbonization of the electrical grid and transportation, changes in healthcare utilization and delivery, implementation of local sustainability solutions, and decarbonization of the supply chain and circularity. And we're going to talk about these last 3 briefly. So it seems obvious, but it's important to point out that clinical care is the primary driver of healthcare's environmental impact. It's relevant because we know that hundreds of billions of dollars of US healthcare spending is waste. I'm not talking about trash, which healthcare also produces a lot of, but rather unnecessary care that comes not only with a high financial cost, but an extraordinary environmental cost as well. We could dramatically reduce our environmental impact by reducing the volume of clinical care that we provide through things like improved disease prevention and advanced care planning at the end of life, by avoiding delivering care in resource-intensive settings like the emergency department or hospital through better chronic disease management, caring for ambulatory sensitive conditions in the outpatient setting, or increased use of telehealth for ambulatory care that doesn't require in-person visits. And by minimizing low-value care, such as unnecessary testing, procedures, or treatments. And we in internal medicine have the opportunity to have a huge impact here because our clinical decisions have so much influence on downstream healthcare utilization. Of course, much of the care that we provide is appropriate. The challenge for us is to figure out how we can deliver care, high quality care, with minimal environmental impacts through implementation of local sustainability solutions. And some examples would include using renewable energy and increasing energy efficiency, using environmentally favorable products like reusable as opposed to single use when appropriate, environmentally preferred purchasing programs, reprocessing certain single-use devices, utilizing low-carbon clinical pathways, minimizing professional travel, including interviews for all of our trainees, reducing and properly sorting our waste, offering plant-forward food options, and expanding employee commuting and remote work programs. And while optimizing healthcare utilization and delivery and implementing local sustainability solutions are critical, We also need to recognize that the majority of healthcare-associated emissions are due to the supply chain and therefore out of our direct control. And while we can reduce the amount of stuff we use in healthcare, we'll never get that to zero. To achieve net zero emissions, healthcare systems will need to encourage and work with their suppliers to decarbonize their own operations, design for sustainability, and increase product circularity, or the ability to continuously reuse products or recycle the component materials. And it's an ambitious goal, but a critical one. And that's true of all the strategies I've just discussed. Ultimately, to make progress, health systems will need strong executive leadership on this issue. Our experience has been that robust clinician engagement has been a powerful tool for driving that change. So with that, I'm going to conclude and turn it over to my colleague, Dr. Mirocha, to help us understand some of the challenges associated with pursuing circularity while simultaneously ensuring patient safety. Thank you.
Thank you so much, Dr. Fury. It is my pleasure to be here today to talk to you about environmental sustainability and the infection control perspective. Next slide. So I want to start by acknowledging the tension that clearly exists between infection prevention and environmental sustainability. Transmission-based precautions, personal protective equipment, and the principles of disinfection and sterilization are truly the cornerstones of our work in infection prevention and control, or IPC. And oftentimes, IPC may support the use of disposable items to decrease or eliminate transmission risk of pathogens. But yet, we must also weigh that the healthcare sector, as we just heard, remains an incredibly carbon-intensive sector, and addressing climate impact requires multilateral and multi-sector change. Next slide. And so I want to take you on a journey where we think about how medical devices and PPE are case studies for acknowledging this tension, and what I hope is a thought-provoking exercise, and hopefully more than that, for all of us. And so to begin the conversation about medical devices, we need to understand the appropriate context in which infection prevention experts think about disinfection and disinfection of medical devices. So this figure shows us the Spalding criteria or Spalding hierarchy. You can see at the bottom of this figure, we have non-critical instruments. These are instruments or devices that come into contact with intact skin or perhaps the built environment around us. These require what we call low-level disinfection, which is typically achieved through the use of a hospital germicidal wipe. In the next section, we have semi-critical instruments. These are devices that come into contact with mucous membranes, and they require something called high-level disinfection. High-level disinfection is a chemical process that typically achieves up to a log-6 reduction in microorganisms or pathogens to prevent transmission of organisms. Examples of semi-critical devices include scopes, typically endoscopes, bronchoscopes, and also endocavitary probes. And lastly, we have critical devices. These are devices that come into contact with normally sterile body tissues, often seen in the operating room, and they require true sterilization. Next slide. So historical key events in healthcare, I believe, have shaped and refined how we think about the Spalding criteria and infection prevention, and influenced our attitude in infection prevention control towards cleaning and disinfection. Not surprisingly, the HIV epidemic gave us insight into transmission of blood and bodily fluids and the use of standard universal precautions, as well as transmission-based precautions. One less discussed seminal event, I believe, is the outbreaks of carbapenem-resistant Enterobacterialis, which occurred between 2012 and 2015. In that time frame, there were about 25, if not more, outbreaks that were recorded of this very resistant organism that was likely thought to be due to ineffectively disinfected or inadequately cleaned duodenoscopes. And it was during this time period that there was significant morbidity and mortality that was discovered due to these events, including patient harm and patient deaths. It launched an FDA and CDC investigation into 2 scope manufacturers. The FDA also launched intensive post-marketing surveillance programs. And I believe that it created increased regulatory might and power for hospital accreditation programming to think about and bring the domains of disinfection and sterilization to infection prevention teams in acute care. And then lastly, and not surprisingly, the COVID-19 pandemic has again brought cleaning and disinfection to the forefront. Next slide. So it was these series of events that I believe brought to bear our current marketplace, which is that out of necessity, we spurred innovation and we created a single-use market, which many believe is here to stay. So in 2019, we had the advent of duodenoscopes created with disposable parts. And at BIDMC, we in fact helped to pioneer one of the first completely disposable duodenoscopes. Not surprisingly, shortly after that, due to issues discovered with the reprocessing instructions for bronchoscopes, a crop of disposable bronchoscopes were created. And then again in April 2022, after the FDA released issues with reprocessing urologic endoscopes, there's now increased use of disposable urological scopes. Next slide. And so this is not to say that reusable devices don't also have their own trade-offs, including environmental costs. So recall that to actually clean and disinfect these devices appropriately, there is time and labor and real expertise that goes into following what I would consider to be very dense instructions for use that are sometimes hundreds of pages to adequately disinfect reusable equipment. For the actual machines that help us to do the reprocessing of these devices, they require real estate, capital costs, preventative maintenance, and there also are additional environmental concerns for reusable devices themselves, such as the water use, energy use, chemical use, and of course, the manufacturing and material cost. Most recently, the FDA and the EPA have jointly investigated the use of ethylene oxide, which is a very common sterilant, but unfortunately now found to have occupational risk with long-term exposure. And only recently has the FDA decided to invest in understanding different ways of innovating medical device sterilization, not from creating a single-use market, but from actually recreating different chemical technologies that can help us sterilize more devices in different ways. Next slide. And so to carefully weigh all of this, we need data, which is scarce. One of the methodologies that might be considered for assessing environmental impact is something called the life cycle analysis, as you'll see in this diagram. The life cycle analysis is a methodology that is used to help assess environmental impact in a cycle in something that we call the cradle to the grave. So thinking about the environmental impact of the raw material extraction needed for the materials to create devices, for the environmental impact used in the production, manufacturing, and distribution of those devices, the environmental impact of the use of those devices, and then finally, in the recycling and in the final disposal of every single element that went into creating those devices. And so we do have some studies in this first study looking at the life cycle assessment of single-use versus reusable laryngoscopes by Sherman and colleagues. It's not surprising that we see an increased amount of carbon equivalence of single-use laryngoscopes, versus reusable laryngoscopes. However, in this next study, we find that there's significant environmental and financial impact of the personal protective equipment that's used to reprocess flexible bronchoscopes. And yet in another study comparing the carbon footprint of single-use versus reusable ureteroscopes, we find that the carbon footprint is comparable. And so it's important to understand that all studies have limitations, but we need studies that require and have the same rigor. Single center LCAs might have different conclusions than larger center LCAs. And so I believe in aggregate, two-scale large life cycle analysis assessments with decision analysis are required to help us weigh environmental and financial impact. Next slide. Moving away from medical devices, I wanted to focus on personal protective equipment as another frontier in understanding this tension. So many of you might be familiar with the now emerging literature of discontinuation of contact precautions for patients colonized with methicillin-resistant Staphylococcus aureus or vancomycin-resistant Enterococcus. At our own institution, we discontinued the use of contact precautions for MRSA and VRE colonized patients several years ago. And not surprisingly, we found that there was significant decrease in the monthly expenditure for gowns by 61% and by gloves by 16.3%, without there being a significant increased incidence in the rates of nosocomial MRSA or VRE. Next slide. In this modeling life cycle analysis looking at reusable gowns done by Vizzola and colleagues, they found in a modeling study that using reusable gowns decreased energy consumption by 28%, greenhouse gas emissions by 38%, and solid waste generation by 93%. Next slide. And yet we have to acknowledge that there is a tension here that requires us to understand also what is happening in different sectors, including regulators, manufacturers, which offer different pricing incentives. And so how do we carry the weight of this environmental and patient risk taken together? It's my belief that the answer here lies in risk stratification and nuance, and that we need to do this together. So, for example, in the most recent American Association of Medical Instrumentation and American National Standards Institute Standard 91, there is now a classification to understand that there may be higher risk scopes, that perhaps not all scopes are created equally, and that some scopes with elevator mechanisms or complex designs may require more intensive cleaning and disinfection, may require a harder look at whether or not sterilization might be a possibility, or may in fact be required that perhaps this is one area where single-use design may be appropriate. In another example, looking at the COVID-19 pandemic, we found that in crisis standards of care, use of elastomeric respirators often actually provided a reusable and sustainable alternative to single-use PPE. And at the heart of both of these examples is the support of the critical concept of the circular economy. And what is the circular economy? The circular economy is something that allows us to think about products similar to the LCA from resource to recovery to waste. So when we think about production, are there opportunities to think about rethink, reduce, and redesign? So for example, are there different ways in which scopes can be designed? Are there more than one just disposable part that can be used for a scope? And then secondly, in thinking about reuse, is there an opportunity to think about different materials that can be used for our scopes, such that they might become heat tolerant, and sterilization methodologies could then be used for scopes? Next slide. And so all of this is to say that I think we're at a very critical time to forge collaboration. This includes with partners in institutional waste stream and waste stream regulation and understanding their corporate social responsibility platforms. It includes also thinking about the national organizations around us, like Practice Green Health, and the solutions that they may offer for healthcare. And lastly, and most importantly, thinking about the local initiatives that might be occurring at our own healthcare institutions. I know, of course, I am indebted to our environmental sustainability colleagues here at BIDMC. Next slide. And so how do we create situational awareness together? I believe environmental sustainability program managers can share their goals, obstacles, and visions with their colleagues in infection prevention control and work with infection prevention control as well as environmental health and safety in establishing partnerships for waste management and recycling. Our colleagues in procurement and supply chain can ensure that infection prevention control as well as sterile processing departments have reviewed requirements for in-house devices related to cleaning and disinfection. Sterile processing departments can share and discuss any operational or regulatory changes and updates. and can identify opportunities for using third-party reprocessing organizations or other potential partners. And lastly, clinicians, all of us, can involve infection prevention control and clinical engineering when making decisions about trialing new equipment or thinking about what we are using in our own facilities. And I know you'll hear more about how clinicians can make an impact in this area next. So lastly, how do we embrace future change together? I believe that infection prevention control experiences can influence policy and regulation, but require joint risk stratification together with all of us. Environmental sustainability and infection prevention teams should collaborate on initiatives to create a comprehensive approach, especially when partnering with other sectors, and that further data is needed to assess the global financial and environmental impact, as well as trade-offs of single-use equipment. And lastly, that national and global partnerships can propel sustainability efforts in infection prevention. It's my privilege now to hand this over to Dr. Armand.
Thank you, Dr. Mirocha, and a sincere thanks to all the department chairs for the privilege of being here, and also Dr. Metley for his past and ongoing support. I suspect that many of you feel the urgency as I do about the climate crisis, and perhaps you also hope, as I do, that we can work together to address this crisis, even through our work as physicians. I will discuss the mitigation of healthcare emissions through clinical practice, focusing on asthma care. So why focus on asthma care? You already heard from Dr. Fury that our current metered dose inhalers, or MDIs, contain potent greenhouse gases. If we look again at the UK National Health Service's pathway to net zero, you see that shifting to low carbon inhalers is not an insignificant piece of their roadmap. The UK NHS estimates that about 3% of their health system's carbon footprint is attributable to MDIs. The UK and US are similar in terms of the proportion of inhalers prescribed as MDIs. And a first pass of our MGB data suggests that our own MDI footprint is on the same order of magnitude. In the US, the emissions from MDI sold in 1 year are equivalent to driving 500,000 gas-powered vehicles for an entire year. And though we see other targets for mitigation, realistically, most of us here on this call are not in a position to greatly influence our hospital energy efficiency or the supply chain. But asthma care and inhalers are very much our wheelhouse in the Department of Medicine and where we can have significant impact. Next slide. Patient education, prevention, and advocacy are tremendously important in asthma care, but outside the scope of this portion of the talk. I'll focus on prescribing. And specifically, next slide, we'll talk about the use of short-acting beta agonists, which I will refer to as SABAs, and discuss low-carbon inhalers, as well as treatment optimization. Next slide. So let's start with GWPs by way of background, global warming potentials. This is a quantification of how much 1 ton of gas will warm the planet over a given period, typically 100 years, relative to that from 1 ton of carbon dioxide. Next slide. Our current MDIs use 2 HFA gases as propellants. They have GWPs over 1,000 to 3,000-fold greater than carbon dioxide. They are better than our prior CFCs that were phased out of the older inhalers, and the goal is to phase out these HFAs through the Kigali Amendment to the Montreal Protocol. Next slide. There are 2 gases with lower GWPs being investigated. It's not clear if they will be approved, and the HFO, which looks great on paper with a very low GWP, is a PFAS chemical. And little is known about the environmental accumulation and potential toxicity. And if they come to market, they will surely be costly. Next slide. The other consideration with respect to gas propellants used in inhalers is the quantity. In this table, you'll see the various albuterol formulations. The 2 available for ambulatory use, Proventil and Ventolin, have the same number of actuations per canister and the same amount of medication delivered per actuation. Yet they differ almost 3-fold in size, essentially attributable to the amount of propellant used. Next slide. We will come back to this infographic later, but note that there's almost a 3-fold difference in carbon emissions with the top arrow denoting the large canister of albuterol and the bottom arrow denoting a small canister of albuterol. With a large canister, each puff of albuterol can be likened to driving 1 mile in a gas-powered car. Next slide. So returning to our thoughtful prescribing strategies for low-carbon asthma care, if you are prescribing SABAs, choose a small canister whenever possible and consider limiting the number of canisters and refills dispensed with each prescription. Not only might this help avoid waste, but it could also sound the alarm for uncontrolled asthma and trigger further patient evaluation when there are frequent refill requests. Remember, 1 canister, 200 actuations is enough to deliver almost 4 inhalations per week over the course of the year. So patients using much more than 1 canister a year are not well controlled. Next slide. Now I'm going to shift gears and talk about the carbon footprint of DPIs, or dry powdered inhalers, as compared to the MDIs. Please don't get bogged down into the details of this slide, but the take-home point is that the cradle-to-grave life cycle analysis of carbon emissions of MDIs in red are about 20 to 40-fold greater than the DPIs marked in green. Next slide. What's more, patients actually prefer the DPIs. This German study, which was not industry-sponsored, taught patients how to use 10 different devices, as identified in this bar graph by 10 different colors. Patients then selected their preferred device, and multi-dose DPIs were preferred over the MDIs, single-dose DPIs, and soft mist inhalers. Next slide. Not only that, when given the choice, 60% of patients would consider switching from an MDI to DPI for environmental reasons, as noted in a different survey. Next slide, please. So how might a DPI compare to MDIs in real-world patient care? The Salford Lung Study was a 12-month primary care study of patients who had symptomatic asthma who were on maintenance ICS, inhaled corticosteroids, or ICS-LABA combination. They were randomized to either a combination of fluticasone vilanterol, which is known as Breo Ellipta DPI, or to continue their usual care with their primary care physician. Next slide. A subsequent analysis showed that the patients that were on MDIs that were switched to DPIs, they reported improved symptoms per the asthma control test, and they required 1 fewer SABA canister over the course of the year, and they had 1/2 the carbon emissions as compared to the usual care group. This suggests that there is no clinical harm, and in this study, perhaps even clinical benefit, and certainly dramatic reduction in carbon footprint with the switch from an MDI to a DPI. So for our second prescribing strategy for low carbon asthma care, consider transitioning to a DPI if appropriate for an individual, including when there is clinical equipoise. But there may not always be clinical equipoise. Next slide. And treatment options abound with nearly 100 formulations for asthma care. So how do we choose? How do we navigate asthma therapy with all these choices? Next slide, please. Well, we know that using SABAs too much is not good asthma care. In the Sabina study, we see this increased mortality signal even at 3 canisters of SABA per year. Intuitively, that makes sense, thinking that the more severe disease drives worse outcomes, along with increased need for SABA. However, the opposite is true for inhaled corticosteroids. With more severe disease, the more ICS used, yet the lower the risk of asthma exacerbations. This suggests that there might be something inherently detrimental with SABA overuse. Using results from the Sabina study, the Sabina carbon study calculated greenhouse gas emissions for asthma care in its entirety, including hospitalizations, ED visits, clinic visits, and medications. Patients with uncontrolled disease had a 3-fold higher carbon footprint compared with patients with controlled disease. And of that footprint, 99%, almost all of it came from medications, not the hospitalizations, and 63% came from SABAs alone. The beauty here is that all of our goals align. Patients do better with controlled asthma, which also leads to lower healthcare costs. This has been well documented. And controlled asthma, we see, lowers carbon emissions. So now, how do we minimize SABA use? The International GINA guidelines since 2019 has included steps based on single maintenance and reliever therapy, which often we refer to as SMART or MART. SMART uses a combined inhaled corticosteroid with formoterol. Formoterol is a long-acting beta agonist, which has immediate onset. So it has unique properties for both maintenance and rescue. Note that this way of using this medication is off-label. Note also that in this preferred track 1, there is no SABA use. Next slide, please. In the alternative non-preferred track 2, a strategy coined PARTIX or AIR is used, and I'll let you read the acronym at the bottom. This strategy involves using an ICS whenever a rescue SABA is used. The US-based NAEPP guidelines has a stepwise approach that is somewhat similar, but includes SMART, is a little bit different, but it does include SMART as the preferred in step 3 and 4. Next slide. As promised, we return to this infographic, and if we are prescribing along the preferred GINA track 1, in the US, budesonide formoterol is only available as a metered dose inhaler, and the one with a more potent greenhouse gas, HFA 227EA. Unfortunately, the Symbicort turbohaler DPI, which you see down at the bottom with a very small footprint, is not available in the US, even though this formulation was primarily used in the trials and is available in Canada, the UK, and much of Europe. Overall, trials demonstrated that using SMART compared to conventional therapies led to a ballpark 35% relative reduction in asthma exacerbations, as well as a 20 to 40% reduction in inhaled corticosteroid use over the course of the year. Now, we don't have any real-world data on carbon emissions comparing SMART directly with the alternatives, but remember that our prior analyses have demonstrated the trifecta of better asthma control, leading to lower healthcare costs and lower carbon emissions. Next slide. If circumstances require prescribing along GINA track 2 using PARTIX or AIR strategy, this means adding a second ICS inhaler to use along with a rescue SABA, as marked by the 2 red arrows and the red bracket. There are many DPIs for ICS, so that combination marked by the green bracket would be an option for track 2 with lower carbon emissions. In the PREPARE trial, authored by Brigham's Dr. Israel, patients had an 80% adherence with the additional ICS inhaler with rescue use. I'd say this 80% is probably at best in the real world, given that adherence may be better in a clinical trial and that the all or most of the time adherence was self-reported, which generally overestimates actual use. There is a new drug coming to town, AirSupra. Next slide, please. AirSupra combines albuterol with budesonide and has been FDA approved. If AirSupra is affordable, that certainly simplifies GINA track 2 and would achieve 100% adherence by definition. It will be interesting to see if this 20+% increase in adherence translates to even better patient outcomes. So for our third final prescribing strategy, consider using SMART. Next slide, please, for better treatment optimization and asthma control. I'm going to tag onto this third strategy, strongly advocating for US access to affordable, SMART, low-carbon inhaler options, by which I mean Symbicort DPI at this point in time. There may be barriers to these 3 strategies, including limited access to low-carbon and preferred inhaler devices, as we discussed, limited information at point of care about cost and coverage, and limited time. It takes a lot of effort to query refill requests, to educate patients, and to transition them to different regimens. But there are resources that help with these barriers, and I believe there are opportunities for even improved solutions through more advocacy and more multidisciplinary collaborative work and more system and process improvements. Next slide. While addressing the climate crisis is daunting and bigger than any one of us, there is a growing movement to empower physicians to take action individually and collectively. Here are a few of the organizations that provide resources and advocacy, including from the government, academic institutions, nonprofits, and physician grassroots organizations. You will be welcome. So thank you for your attention, and we look forward to a discussion with your questions and comments.
Thank you very much to all the panelists. That was a really sobering session, but also one that really gives us a direction as to what we might be able to do collectively as a community to try to solve a problem that affects us all, and particularly our patients as healthcare providers. So thank you for all the background information, and I think it'll be very useful, not only for our conversations with patients and colleagues, but also about institutional measures that we take. So we have one initial question. I have one of my own, but I will ask one from Dr. Reynolds. Question is, have there been any EMR solutions, so something you could put in Epic perhaps, where you would try labeling medications with, say, green and red labels, similar to what happens in the grocery store, for example, to say what is healthy and what is not healthy, what is sustainable, not sustainable, so that when somebody is ordering, is not only paying attention to, whether it is covered by insurance, whether it's a preferred, in the formulary, etc., but also what is more sustainable, for example, on the inhalers, etc.
Yeah, I'd be happy to answer that question. I'm not aware of any particular initiatives like that. And I think one of the challenges is that we just lack the necessary data to be able to include that information in the EHR in many ways. And honestly, it starts above that, kind of at the level of supply chain, where people who are making decisions about the products that we're purchasing just don't have access to information about the environmental impact of the different products that we use. And ideally, that is a place that we would get to, but it involves a kind of labor-intensive process of conducting LCAs, life cycle analysis of all of these products, so that we can actually have really kind of rigorously obtained data that allows us to compare between the products. That is an area that I think that is one of the areas in which we find, I think people who are advocating around healthcare sustainability really moving, is trying to encourage our suppliers to begin investing in gathering that data. So we don't have it at the moment, but I think that is ultimately a priority in the future.
So I guess it's related to another question that just came in. I suppose that sort of labor-intensive study of the various medication options would also be necessary for example, pressuring or at least influencing the FDA about their approval of products in a way that would also make those assessments, so that then the FDA might be able to go back to big pharma or to insurers and make better products as well.
Yeah, and I think to follow up, I agree. I think that is one of the mechanisms that we could be using in order to encourage device manufacturers and pharmaceutical companies to be supplying that information, is really to just make it part of the regulatory process. And I would say that is one of the areas in which there is like pretty significant advocacy work going on currently.
Just a follow up here from Dr. Silver, who has the question was whether the FDA might require life cycle data, for example, every time a medication is submitted for approval, then that the farm manufacturer would be on the hook for providing that sort of information.
Exactly. Yeah, and I think that's where we're hoping things are going to go.
Great, wonderful. Another question. Great talk by all the speakers from Dr. Matthew. Along the lines of labeling products as red or green, or you could choose your colors, by the way. Can health systems request their vendors to disclose the carbon footprint of the companies that provide such products?
I'm going to answer this one too. I'm not trying to take away from my fellow panelists, but only because I'm involved in some of this work through an organization called the U.S. Healthcare Climate Council, which our hospitals are a member of. And we are actively working on that right now, which is how can we begin to encourage or pressure our suppliers to begin disclosing their own carbon emissions. Many of these are kind of large companies, and so I think there's hope that with this new SEC ruling that's going to require large corporations to disclose their carbon emissions, some of that will be done for us. But I do think that in combination with other health systems, as well as our group purchasing organizations, through which we buy much of the stuff we use in delivering care, that we are going to be able to begin pressuring companies to supply that information, and not only their own footprint, but also declaring that they are going to commit to a specific strategy to reduce their own emissions by a certain amount over a certain time frame, ideally in line with something called the Science-Based Target Initiative, which is kind of a globally accepted standard for achieving and maintaining global temperature rise less than 1.5 degrees Celsius over the next century.
I have a question for Dr. Mehrotra, and maybe it's a comment and then followed by a question. It has to do with the decision to discontinue contact precautions for MRSA and VRE colonization. I understand, that is not the practice at Mass General, and it's a little bit of a area of controversy, perhaps, where some of the individual studies may show that there's no difference, but maybe they're not looking at all the relevant outcomes. For example, for infection, and there's guidelines from the multi-societies for prevention of MRSA that does recommend the use of contact precautions, and then a recent study in the VA across the entire system, so very large, where hospitals were given the choice of different levels of precaution, whether you simply you use active surveillance or contact precautions for colonization, contact precautions for infection, and then the hospitals that had the lowest rates of reinfection were the ones that applied the most stringent. So I think it is a little bit of a point of contention, and the evidence is still being gathered. I guess one naive question I would have is, what is the relative carbon footprint of the use of disposable PPE versus the old way, in which we would have something that would simply be washed? So it would be cloth PPE, and then that would be used and put in a hamper and then eventually washed. Which one actually generates the worst carbon footprint?
It's a great question, and you're rightly identifying that there is still a fair amount of controversy related to the use of contact precautions or discontinuing contact precautions for patients colonized with MRSA or VRE. And you are right also identifying that, there are multi-society guidelines that still do support the practice. Having said that, there's an equal number of studies in both directions, and this is heatedly debated at basically every single Society for Healthcare Epidemiology conference now, I'd say the last 5 years, in sharing each experience and institution's data about the discontinuation of contact precautions. I will say that, as I noted, really there's just that one modeling study that I showed that compared reusable gowns versus single-use gowns. But to your point, a complete life cycle analysis, not just at one facility, perhaps, but by region, would need to take into account the entire laundering that would be required and that is required for reusable gowns. So I think there's two separate questions there. One is specifically about the use of gowns in general for contact precautions, which we can heatedly debate, and I would always add, and I take every opportunity to give a plug for hand hygiene. But then I will also say that separate as a question looking at reusable versus single-use gowns or disposable gowns, I think there's a lot more data that we could collect.
Okay, so maybe to follow up on this conversation a little bit, maybe everybody can comment, but let's start with you, Dr. Mehrotra. Dr. Reynolds asked, there is hospitals are under different pressures. And for example, they need to document lower rates of reinfection to be able to meet metrics that payers demand and quality assessors demand and the Joint Commission, et cetera. We're about to have a JCO visit this winter. And so we need to really make sure that we are fulfilling those. And so you have that as a must fulfill measure. And then you have this sort of aspiration on the ethical side of things that is maybe a little more ethereal and difficult to convince. And so as a hospital administrator, how do you prioritize, which one to pay attention to? And can we kind of thread that needle?
I think the reality is we have no choice but to try and thread that needle. So yes, absolutely. I count me in the camp of individuals who are beholden to regulatory standards, who are involved in Joint Commission pressures, who are involved with understanding in particular how disinfection and sterilization are at the forefront of hospital accreditation programming, particularly when it comes to patient safety and preventable harm. But I think it would be remiss if we didn't also make the case that not thinking about climate health is another area where we are letting preventable harm occur. And so I think there are regulatory entities, including the Joint Commission, who are understanding this and who are testing different methodologies of incorporating sustainability metrics into their own processes and observations, and have recognized a fair amount of waste that is included in the infection prevention standards that exist. So I think in reality, we need to weigh all of this together. It may take, and it will take time. And I think that at certain opportunities, at certain times, one might supersede the other. But I think that's much of what happens in how we practice in healthcare.
So another question connected with that, the last statement, how we practice in healthcare. I don't know about your respective hospitals, but in our hospital, it's quite common in the medical service that every patient automatically gets a blood draw every day, because you need to know what the potassium and the BUN9 creatinine and the CBC is on every patient every day. And I imagine that the carbon footprint generated by daily blood draws that are maybe unnecessary is substantial. Do you think that would be a potential area for intervention? What, how would you try to change the culture?
I can address that. I think that, as actually Dr. Fury mentioned, the importance of looking at whether we are practicing low value care versus high value care. And just, I think hopefully with time, it'll be ingrained into the culture. I think right now it's a work in progress, because I think there are so many other tensions and just to the traditions of how medicine is practiced. And I believe, Dr. Fury, you can speak to this. There was a resident, Peter Trin, who actually did a study, I'll pass it to you, about the issue with blood draws on a daily basis.
Yeah, so there's a group of residents at the Brigham who are interested in this specific question. And so they have actually, in partnership with Dr. Katz, they have been leading essentially a trial looking at providing an educational initiative at the beginning of residents' block on a particular service within internal medicine, and essentially providing some information about low value care, but also really tying it to this environmental question and using that to see whether it motivates change. And so I think it's a specific example looking at precisely the question you referred to about kind of low value care and necessary lab tests. But there are many, many examples of this. And I think we need to begin quantifying the potential impact of low value care from an environmental perspective, not just a financial perspective. And to, I think, your other question, that is one way of really driving change at the health system level, because there's huge expenditures here. And if we can provide further incentive for reducing costs of care, then that's a compelling argument for leadership of our hospitals.
And one potential solution mentioned in the Q&A here is that perhaps we should be using pediatric tubes. I mean, maybe that would have an impact. If you really need that blood draw, you could use pediatric tubes. Yep. Great. So another sort of general question, how you motivate people, maybe we can close the session with this. Some people I think that people that are hard to convince, some people you will never convince on the fringe. But then the people that are sort of hard to motivate are people who say, fine, we can do this, but really the biggest emitters are outside the United States, or they are in other places. And so what we do in healthcare is only going to be, spit in the bucket. So how do you really motivate those people to show that even our piece is important? I just learned recently from the Pope, of all people, who just issued some letter on climate change, who said that while it is true that, say, China produces more carbon emissions than the US, per capita, a US resident produces twice as much carbon than a Chinese resident. So how would you motivate people?
I would just add on to that to consider the fact that, yes, China may have large emissions, but a lot of it is manufacturing of things that we're purchasing. So if you look at our footprint of 80+%, a lot of that is because we're purchasing things that are made elsewhere.
That's a great answer. Well, I don't know if anybody else has one last few words. Otherwise, we'll have Dr. Reynolds close the session.
I want to thank our three speakers today, Drs. Fury, Armand, and Marotra, What a great motivating conversation. Gave me all sorts of ideas and motivations around my own practice that I hope to be able to implement. We are excited for next month's Harvard Medicine Grand Rounds. It will be held on November 2nd from 8 to 9 as usual. It will feature Doctors Hyder Warwick, Rishi Wadera, and Jason Wasfy, who will be speaking about implementation challenges in cardiovascular disease, transforming promise into progress. Hope to see you all on November 2nd. Have a great week and weekend.